We are going to talk about the trends globally and in Bangladesh, a little bit about the Choosing Wisely program, which I've been involved in, including in India, and how that relates to breast cancer early detection and some sort of, let's say, framework for you to consider, even though I know it's primarily a room full of highly well-trained clinical folks. I'm actually a medical oncologist by training, but I haven't treated patients in over a decade. Been working on the cancer genetics side and increasingly on the global health side. But I think it's important to have some framing of this during this important course for all of you, and putting that into context of what's called the Global Breast Cancer Initiative that some of you may not have heard about yet because it's fairly new. So it's probably not surprising to any of you here watching is that every minute a woman dies from breast cancer globally. And most women who are dying of breast cancer were living in a low or middle income country. And that's almost 700,000 women in 2020. And most of these deaths, most of the women who die were under the age of 70, what we call the premature death. And many of these women died of a preventable cause. Not from primary prevention so much as from having equitable access to high quality diagnostics, early diagnosis, treatment, and appropriate follow-up, such as what you're all doing here. So if you look at the countries globally, we can see here, this is the age standardized incidence rates from GlobalCan. I encourage you also to check out the website because a new effort was just launched this week here at IARC called Cancer Tomorrow, where not every country, I'm sorry that Bangladesh isn't among them, but many countries are included in this new way of visualizing trends over time. But you'll see some of that here. When you look up GlobalCan, you can also look at the Global Cancer Observatory, which is really where you're going to find all of this data, new interactive features. That's my little plug. You can see here the world looks pink. So why does the world look pink? The world looks pink because when you look at, in fact, both sexes in terms of incidence, and here we're just looking at women, the number one cause of cancer in women globally is breast cancer. In most countries, in 158 countries, it is the top cancer among women, except for some countries. Take a look here and see where Bangladesh fits, where cervical cancer is still greater. And in terms of deaths, we still see, unfortunately, cervical cancer, believe it or not, is the number one cause of cancer-related death among women in 41 countries. And I draw attention to this because I think it's important to get a sense of what's happening in other countries in the region, et cetera. And here we see the blue. This is actually lung cancer. And the reason why I'm showing this in North America and in Australia is that lung cancer quite a while ago actually surpassed breast cancer in terms of the number one cause of cancer-related death among women. Good news, bad news story, right? We've seen this peak of smoking, which is not a major issue among women in Bangladesh. I'm aware of that, although you do have smokeless tobacco products that are a cause of other cancers, oral cancer. But this is also a story of better early diagnosis and improved access to all women for highly effective treatment. So by the numbers, we've got about 19 million new cases of cancer globally and 10 million deaths among men and women. And for women, about 1 in 6 will develop cancer in their lifetime and 1 in 11 will die. Most women and men who are dying of cancer, this is occurring in Asia, Africa, and Latin America, with a massive increase in the next 20 years. Just to give you a little quick snapshot of this, between 2020 and 2040, we're going from 19 million cases of cancer in the left panel in 2020 to almost, well, over 30 million cases of cancer by 2040. A lot of that is due to demographic changes. That's what the light blue here refers to. This is for men and women, meaning aging population and the epidemiological transition and the demographic transition is causing a lot of this increase and not something in the environment, for example, that people might wonder about. When we think about the deaths, we see almost 10 million deaths in 2020. This will jump to 16.3 million deaths in 2040. And this is all from IARC, the WHO's cancer agency. So what does this mean in Bangladesh? Well, in 2020, this is the last time that GlobalCan has reported, we see that the breast cancer deaths are far outweigh any other cause of cancer-related death in women in Bangladesh. And we see the mortality here against incidence You don't have to be a statistician to see that that is far, far higher in terms of the case fatality, the likelihood a woman who develops breast cancer will die from that disease in Bangladesh compared with, say, Canada, which, by the way, is my country of origin, but I live in the US now. In terms of, this is Bangladesh data, trending from 2020 to 2040, we saw that in 2020, there were about 13,000 women who died of breast cancer in Bangladesh. And by 2040, that's a huge jump. 22.6 thousand women are expected to die of breast cancer if something doesn't change. So we're going to talk, sorry, that was diagnosis with breast cancer. In terms of deaths, we have about 6,000 women who died of breast cancer in 2020 in Bangladesh. And this is deaths now. That is going to jump 92% to 13,000 deaths. That's a huge increase. And the rest of the talk will be sort of framing that in terms of what's going on globally and how we can help each other to improve equitable access to not so much primary prevention, but certainly secondary prevention. And what does that really mean in the Bangladesh setting? I know I haven't been there for a number of years now, but I have been trying to follow along the situation for most women in the country who don't live near high quality breast cancer center or high quality tertiary care cancer facilities, such as what you have in the capital in Dhaka. On the left, I've shown this slide many times, and some of you will have seen this before. This was a mammogram from Ontario, Canada, where I used to work in prevention and screening and also treatment of women. And you can see you're all sophisticated in this room. That's probably a T1 tumor, less than a centimeter, probably stage 1 node negative. This woman on the left panel is probably 60 years old. That would be the average person I would have seen in my clinic or in the mammogram screening centers. Whereas on the right-hand panel, that was actually a real photo of a woman who I saw in Khulna in our breast clinic back in probably 2010. And she had a fungating mass, and she was unfortunately one of many women who I saw that day who presented not for the first time, but who ultimately presented to somewhere where they could get a proper diagnosis and access to treatment when it was unfortunately very, very late. And so I'm going to talk about the Global Breast Cancer Initiative, which is a recent effort of WHO and partners around the world. Just to say this one statement, and then I'll come back to the GBCI towards the end of this talk. I'm going to try to limit this talk to about 30 minutes so we have time for questions. Breast cancer survival 5 years after diagnosis globally now exceeds 80% in most high-income countries. And that's a combination of early detection, but also, as I hope you'll be convinced by the end of this talk, improvements in awareness, education, lowering the stigma, reducing, counteracting the myths about breast cancer in the public, and also providing access to high quality treatment. So we're looking at 5-year survival of greater than 80% altogether. If you look at stage 1, obviously it's higher. And that compares with 66% in India and 40% in South Africa. Where Bangladesh fits in is probably somewhere in between those. The premature deaths and high out-of-pocket expenditures that arise when breast cancer services are unavailable or unaffordable results in social disruption, impoverishment, family instability, and also orphaned children. This threatens economic growth. And I know I'm speaking to, again, a room full of people who treat breast cancer, so you know this because you see this, sadly, in the families of the women who you've been treating. So the question always comes up, and I'm sure you've had this experience as I have had also in Canada, but in many other countries where I've worked, including when I was at the World Health Organization some years ago. Why didn't she present sooner? I get asked this a lot. And sometimes I have been guilty of asking that question myself to the woman. Why didn't you come earlier? Well, we did a study that actually looked at that, and we published it almost 10 years ago in the International Journal of Breast Cancer. I'll show that in a moment, and the link is there on the slides, which was a snapshot then of breast cancer in Bangladesh. And the question about presentation comes up here in this talk because I want to draw your attention to the importance of not blaming our patients. Like I said, I've done this as well. when we actually asked in a proper forum, individual interviews and focus groups, most women had in fact presented to someone quite early when they noticed they had a breast lump. They knew it was something potentially serious, but there were many factors that made it difficult for them to finally get diagnosed late, right? Concerns about having choice. If you are very impoverished and you have very little money to put towards health of yourself, let alone your family members, and you've never met anyone who has survived breast cancer, which was the case in Kulna, and maybe that's changed a lot in the last 6 years since I've been there. If you've never met anyone who survived cancer, why wouldn't you think it's a death sentence? And what would be the point of spending your money, taking yourself away from your family responsibilities in order to have treatment, but you're going to die anyway? And so this is the stark reality, not just in Bangladesh and some rural communities. Maybe it's a lot less so now. I hope so. But this is a situation in many countries where folks like myself and with the National Cancer Institute in the US and partners at the International Atomic Energy Agency, the other UN agencies, we come sometimes at the request of a country, Ministry of Health, to do a deep dive into the cancer situation. And we often find very similar stories globally. So why is this growing? Why are we seeing so much more breast cancer, so much more cancer in particular, but breast cancer being the subject of this talk? Why are these girls and women facing higher risks year by year than we see actually in countries that have already gone through massive economic development? We still see a little bit of an increase in the true age standardized incidence rates, right? But nothing like what we see in most middle income countries that are going through their transitions. And so some of that, I think you already know, is the epidemiological transition away from infections towards non-communicable diseases, cancer being just one. And increasing exposures to, this is for all cancers, because I know tobacco isn't a major risk factor for breast cancer, but tobacco, alcohol, poor diet, and sedentary lifestyle. Overweight and obesity plays almost a central role in the increasing rates of breast cancer, especially postmenopausal breast cancer in all countries. And so that compounded with the hormonal exposures, exogenous hormones not being so much of an issue anymore, as we now know that we need to be very judicious about how and under what circumstances we recommend combined hormone replacement therapy to women after menopause. That's a whole other discussion. But the exogenous hormones, but endogenous hormones, of course, play an important role. And in every country where it's been looked at, as the economic development proceeds and people are living longer and nutrition improves, but of course the counterfactual there is it improves to the point where people have too much access, and that creates the problems with overweight and obesity. We see a decrease in the age at first period at menarche. We see girls staying in school longer, fantastic, great marker of development, not being forced into marriage, starting their children when they want to, spacing them appropriately, having fewer children. This was a good news story in Bangladesh as it met the Millennium Development Goal, and actually, it not like it's a competition, but did it better than India did, neighboring country with a greater GDP, in terms of fertility and maternal mortality and child mortality. All of these are in the right direction. But these all drive the risk of breast cancer, right? Less children, delayed childbearing, less breastfeeding. All of those, except the less breastfeeding part, are fine. But how can we help promote factors that are modifiable to help reduce, at the primary prevention level, the risk of breast cancer? So that's just a question I'll put to all of you. And what are the other factors? And to what degree are the other factors really modifiable? And I don't have time today to go into it, but the Lancet Commission that I'm actually chairing with two of my colleagues, Dr. Isabel Sawyer-Mataram, who is at IARC, and Dr. Verna van der Pooy, who's a radiation oncologist in Accra, we are also taking a harder look at the commercial determinants that drive some of the risks, particularly related to overweight and obesity, but also alcohol. I know this isn't a major issue, or perhaps you'll tell me otherwise. Didn't used to be a major issue, particularly among women. The drinking rates are quite low in Bangladesh. But just since we're talking globally, this is a big concern. And there's been recent work at IARC showing to what degree alcohol can influence breast cancer risk among women. So I'm going to switch gears a little bit and now get into what is the guidance globally. According to the World Health Organization and IARC, there have been documents, position paper on mammography that some of you would know about from 2014. And a few years later, IARC also produced a handbook of cancer prevention as their handbook series on breast cancer screening that took a look, very deep dive, detailed systematic review and synthesis of the evidence showing overall what mortality reduction we'd expect from mammography, about 20% in total with a certain degree of overdiagnosis. And I'm not here to debate the pros and cons of mammograms, but just to note, what are the system requirements under which circumstances it is a wise decision to invest in population-based mammographic screening in any country? And that's sort of what I want to get to now. This brings us to the choosing wisely concept. So the World Health Organization in 2017 put out the Guide to Cancer Early Diagnosis. Early diagnosis is a different animal from screening. And I'm going to just mention that just so we're clear on our terminology. I had the good fortune, I was at the World Health Organization 2015 and 16 and helped put together this guide. You all know this, I'm sure, very well, but just to remind ourselves really what the difference is and make sure early diagnosis is distinguished from screening under the umbrella, which we still, for want of a better term, call early detection. Under the umbrella is screening on the one hand. Asymptomatic individuals at risk are invited to participate in programmatic effort to detect cancer before it is symptomatic, whereas early diagnosis on the right panel is for women to recognize and for providers to know what to do when a woman does present with a breast lump or another suspicious finding, and to get them through that care pathway. So early diagnosis equals early and effective treatment to completion. And so just 2 points from this book that are relevant to this discussion is that promoting the early identification of cancer without appropriate access to treatment is frankly not just ineffective, but it's unethical. And the establishment of a successful and systematic management of clinically palpable, detectable breast disease is essential before implementing population-based screening. That's not to say that if you are working at a facility now where there's opportunistic screening and some women do come for screening with mammograms, that's wrong. But just to look at it from a programmatic standpoint, from a public health standpoint of what makes sense in a given country, because the resources are limited. They're limited in every country. We don't have endless resources in Canada either, for that matter. But we were able to put together a population-based mammogram screening program only after we could assure that every woman who had palpable breast mass had access to a diagnostic imaging test, a biopsy, obviously a physical exam, what we call triple diagnosis, et cetera, et cetera. And the health system was functional to that extent that could afford, not just in terms of financial affordability, but could afford to have a huge program where all women of age, in Canada, it's age 50 and up, are able to access free mammography with diagnostics and treatment. And those are the two position statement on the left and the breast screening volume I mentioned on the right from IARC. I can add the URLs if people are interested. And this leads us to the beginning of what became the Global Breast Cancer Initiative. It began with, I'm sure many of you have heard of Dr. Ben Anderson. I'm wondering if he's actually lectured in this series before. Dr. Anderson is a breast surgical oncologist, formerly at the Fred Hutchinson Cancer Center in Seattle at the University of Washington. And he is now a consultant at WHO in Geneva, working on this global program. But in the early years, for about 10 years, every couple of years, there was a summit of what he called the Breast Health Global Initiative, the BHGI. And it started out with this idea that he had for stratifying care, prevention, treatment, diagnostics, and care for breast cancer on the basis of a good estimate of the resources you have in a given setting. We call that now resource stratified frameworks, and you'll see this in NCCN, assuming you also use NCCN still for your major guidelines regarding treatment. So NCCN now has this resource stratified framework for a number of cancers, not just breast cancer. And I was involved in leading the breast cancer early detection part of the last summit, which was in 2018. And I encourage you to look at the whole series. It's all open access. This is a really busy slide. I'm not going to go through all of it, but just to say, we actually tried to map out and now call this the universal patient pathway, which more or less is divided into three. The first one, I personally don't like this phrase patient interval because it blames sounds like it's blaming the patient, but it's that whole interval of time before a woman reaches diagnosis. Okay. You can call that pre-diagnostic. Then there's the diagnostic interval, and look at all the things that have to happen in order to get a diagnosis. This is all before they see you, the provider, the clinician who's going to be advising them on the appropriate treatment for breast cancer. Sometimes it's worth thinking about what happens before the woman comes to you. And then the treatment interval, of course, you know all about this. So I'm going to just highlight this piece. The diagnostic interval has now been, let's say, set as a target that this should be no more than 60 days from the time a woman presents to the time she starts her treatment, if she in fact has invasive breast cancer. This shows the implementation roadmap. I'm not going to go through it, but I encourage you to look at this paper if you're interested. It basically talks about what I just said, assessing the current treatment availability and diagnostic capacity, including pathology services, which I know are a limitation in many countries, including Bangladesh, especially in the public health system. Strengthening early diagnosis based on the triple test evaluation, as I said, a clinical exam, a diagnostic imaging, and a tissue and appropriate pathological evaluation. And then, et cetera, reliable systems to stage, identify cancer subtypes, define the targets that you want from diagnosis to treatment initiation, plan for palliative care in patients for whom treatment with curative intent is not feasible, use of multidisciplinary teams, everything you're already doing and you're hearing about in this course. We also want to draw attention to the importance of implementation science methods to understand the context, the barriers, the facilitators, how to evaluate and improve ultimately the women in your community's access to getting that diagnosis and care effectively, and to being able to complete their care without having to sell their homes or farms, or unfortunately have terrible toxicities, which might happen if they're not actually managed in a context such as where I think everyone here is working. So just ending on a few slides about the Global Breast Cancer Initiative. This was published in The Lancet in March by my colleagues, including, of course, Ben Anderson. It's a major new collaborative effort, including the regional offices, and we hope the country offices of WHO, as well as, of course, national cancer institutes and clinicians, providers, anyone really passionate about improving breast cancer control in their countries and globally. The objective is to reduce global breast cancer mortality by 2.5% per year until 2040 to avert an estimated 2.5 million deaths. Now, where do they get that 2.5% from? Is that pie in the sky? Is that unrealistic? In fact, it's quite realistic, because we've seen in many countries, including Canada here, Ireland, France, that we've more or less seen that 2.5% reduction in mortality over a period of decades, where there was not just screening, and again, coming back to screening versus early diagnosis, there was access to an effective health system that could take a woman from the time of either detection by screening or a palpable mass through to treatment completion. We can see the same is happening in many other countries, including some in Europe and some in former Soviet republics, et cetera, even Mexico and Peru to some extent. We're seeing improvements even where you don't necessarily have screening. This is just a quick snapshot of the objective and pillars of this Global Breast Cancer Initiative. And we've just held our second technical consultation. I'm on one of the working groups. Health promotion is the first pillar to improve early detection. 2 is timely breast diagnostics, coming back to that core issue about how to get women diagnosed appropriately and early, and comprehensive breast cancer management. And lastly, this paper that just came out this month by Catherine Duggan, who's part of the Breast Health Global Initiative now, the Global Breast Cancer Initiative. They took a look at national health system characteristics, breast cancer stage, and breast cancer mortality in a population-based fashion. And you can see here Dr. Freddie Bray, who's the head of the Global Cancer Surveillance section, where I have the pleasure of spending some time now at IARC. The main thing here is they looked at the WHO cancer country profiles. You can look up Bangladesh's online. The health system characteristics that they looked at included the degree to which universal health coverage is actually being applied. So not just whether the country has universal health coverage, because that can vary tremendously, what's included, to what degree is it actually leading to service delivery. And there's an index for that. Then looking at dedicated funding for early detection, breast cancer guidelines, et cetera, and also the number of dedicated public and private cancer centers per 10,000 patients, as well as pathology services. And they found that among 35 countries with available breast cancer staging data, all 20 that achieved sustained mean reductions in the age standardized mortality rate of 2% or more per year. Okay, like I just said, that 2.5% per year for at least 3 consecutive years since 1990, what we call a sustainment, had at least 60% of the patients with invasive breast cancer actually being diagnosed with stage 1 or 2 disease. So that's really critical. That's really the takeaway from this paper. And the second most important takeaway is that some countries achieved this reduction without most women having access to population-based mammographic screening, coming back to that issue of what is relevant perhaps now in Bangladesh. And finally, the invasive cancer stage distribution showed that all countries with sustained mortality reduction had more than 60% of cases diagnosed at stage 1 or 2, and no country that didn't have more than 60% of the women diagnosed at stage 1 or 2 achieved sustained mortality reduction. That might seem obvious, right? Okay, stage influences survival, so it should influence mortality. But in fact, at a population level, this kind of study has never been undertaken. So I would really encourage you to take a look. It is an open access paper in the Lancet Oncology from this month. And the interpretation more or less is that, we're reinforcing the value of clinical early diagnosis programs. Okay. Not that you can't do screening, but we really need to emphasize the importance of using whatever resources you have towards early detection first to improve capacity for diagnostics, right? And health awareness and provider awareness before they come to you in the tertiary care center. And I think I'll end there. It's almost, the half-hour mark of the talk, and hopefully there'll be some questions. Thanks so much.